Hi, everyone. It's Heather Vernillo, and I am doing a lecture this evening on your chapter 17, which is your assigned reading for this week, and it is on sleep-wake disorders. So hopefully you've had a chance to read it. If not, you're going to follow along with our lecture here. So your learning outcome is to summarize the impact of biological, psychological, sociological, cultural, and spiritual domains on normal sleep-wake states. All right, so sleep is a natural state of rest during which muscle movement and awareness of surroundings diminishes. Sleep is essential to restore energy, maintain physical and mental well-being. It allows us to function optimally. And unlike other states resembling sleep, such as a coma, sleep can be easily interrupted or prevented by external and internal stimuli. External stimuli include light, noise, uncomfortable sleep environment. We can have internal factors like stress and anxiety that can impair an individual's ability to achieve quality sleep. Now, you learned about circadian rhythms. That's your biochemical, physiological, behavioral processes that are driven endogenously, and it spans a 24-hour cycle. You can hear this talked a lot about our night shift workers because their circadian rhythm, their natural body's time where melatonin and things are released to signal a time for sleep, they are actually going in reverse. Nurses must be aware of respiratory vulnerabilities during sleep and altered state of consciousness. If you give somebody a opioid analgesic, you need to be aware of their respiratory vulnerability, especially if that person then goes to sleep, because if their respiratory rate falls below 8, you're going to need to intervene. It's been estimated that 35.2% of adults in the United States experience chronic sleeping problems, and that comes from the CDC. Nearly 1/3 of patients seen in primary care settings report occasional sleep difficulties. Quality sleep is recognized as a priority in the national health as indicated in our goals of Healthy People 2020. This chapter discusses your major sleep disorders, breathing-related sleep disorders, circadian rhythm sleep disorders, narcolepsy, hypersomnolence, insomnia. So sleep is a reversible behavioral state of perceptual disengagement and unresponsiveness to environment. And it's controlled by lots of complex systems. And then wakefulness is the opposite of sleep, and it involves the same processes, but in reverse. And sleep disorders can lead to sleep deprivation, which can seriously interfere with a person's overall functioning, including impairment of one's family life, their occupation, their ability to drive a car, and their social activities. And medical costs related to sleep disorders amount to about $63 billion annually, with indirect costs incurred from such things like lost productivity at work. Chronic sleep deprivation can cause or contribute to accidents, social and marital disruptions, worsen psychiatric disturbances. It's also an independent risk factor for cardiovascular and gastrointestinal disorders, which is why you will see obstructive sleep apnea a lot of times written as a comorbid diagnosis along with someone's psychiatric illness when they are presenting in a psychiatric office. Now, sleep disorders can be acute and they can be chronic. They can occur primary or secondary to a medical or a mental health disorder from substance misuse, environmental factors. There's various medical conditions that can cause sleep disorders, including things like chronic pain, neurodegenerative disorders like Parkinson's disease or Huntington's disease, viral encephalitis, thyroid disease, hormone imbalances, especially for our perimenopause and menopausal woman. Mental health disorders like depression, anxiety, schizophrenia most commonly are the cause for insomnia, in the mental health arena. And high levels of stress can contribute to these sleep disorders. Substances that can disrupt sleep are things like alcohol, caffeine, and prescription medications, but most notably, antihistamines, corticosteroids, and any CNS stimulant. So we have your biological domain, cycling of the brain activity, low frequency, high amplitude. There's different bands. They can actually, if you have someone hooked up to a EEG, you can actually see these sleep patterns and bands, in a picture form. We have different phases of sleep. So sleep occurs in 5 different stages. And with each stage, sleep becomes deeper and those brain waves grow larger and slower on an EEG. So using an EEG to identify disruptions of these stages, an evaluation of the wave pattern, it gives us a lot of information about potential sleep disorders. Throughout sleep, a person cycles through these different stages over and over again, with the first cycle lasting about 100 to 120 minutes. And most people will go through about 5 to 7 cycles per night. And if you wear like a Google Watch or an Apple Watch or a Fitbit that tracks your sleep, you can actually go back and look at the quality sleep that you've had. And then if there's nights where you haven't had the greatest of sleep, like you can kind of pinpoint, all right, well, I had 2 glasses of wine at dinner, and then this night I didn't go into deep sleep. I stayed in light sleep for longer than I usually do. So it kind of like lets you go back and get that statistical analysis of what's going on with your sleep pattern. In stage 1, that is our light stage of sleep. It occurs as you're falling asleep. The muscles will relax, the theta waves are produced, they're fast, they're irregular. During this stage, the person can easily be awakened by sounds, light, or any other stimulus. Individuals can also experience muscle spasms or like different kind of jerks of the leg as they're, entering this stage of sleep. Stage 1 accounts for about 5% of an adult's total sleep time, and it really only lasts about 15 minutes. In stage 2, this is still a relatively light stage of sleep, but we're considering this the first stage of non-rapid eye movement sleep, that NREM. The theta waves continue, but they start to become interspersed. There's little sleep spindles, which are like sudden increases in the wave velocity and the wave frequency. There are K complexes, which are increases in the amplitude. The waves start to get higher. It's hypothesized that these complexes and spindles actually protect the brain from awakening. Stage 2 compromises about 50% of the total sleep time. So in this stage, your heart rate slows, your body temperature decreases, the muscles relax more, and the body starts to prepare for that deep sleep. As we enter into stage 3 and 4, those are your deepest stages of sleep. This is where we get delta waves. Delta waves are large, slow waves of high amplitude and low frequency on the EEG reading. Stage 3 and 4 differ only in the percentage of the delta waves seen. During stage 3, delta waves account for about 50% of your brain waves, whereas in stage 4, they account for like the other 50%. So stage 3 and 4 are where the sleepwalking, sleep talking, those things known as parasomnias, that's where they'll occur. And arousing a sleeper from stage 3 or 4 is harder than during any other stage because this is marked by a decreased body temperature, decreased metabolism, and researchers believe they function to conserve energy. They account for about 10 to 20% of the total sleep time, and as night fades into morning, stage 3 and 4 get progressively shorter. And during the last few cycles of the sleep period, no delta wave are seen at all. And during your REM, your cardiac rhythm, your rate fluctuates due to that parasympathetic influence. We get a vagal mediated decel that diminishes with age, and arrhythmias could contribute to that sudden cardiac death during sleep. So most of people's dreams take place during that REM sleep. People awakened from REM sleep can report and remember vivid dreams that occurred during that stage. And if people who are awakened in other stages of sleep usually cannot tell you what they were dreaming about. Scientists believe that REM and non-REM sleep serve different biological functions, although they don't exactly know what these functions are. REM sleep can stimulate brain growth and consolidate memory, and a person deprived of REM sleep tends to have longer REM cycles during the next sleep episode. Now, if you take medications like the Z drugs, Ambien, Lunesta, they will keep you from getting into that REM stage. They'll keep you more in a light sleep throughout the period. So you're asleep, but you're not in deep sleep. You don't go through the stages. So you wake up the next day and you're actually not really that refreshed, and you can only handle so many days a row of not getting REM sleep before it really starts to affect you. Affects your personality. It affects, your energy levels, your mood states, everything. Depression and anxiety can occur when an individual is deprived of sleep. Disrupted sleep can occur due to depression and anxiety. So it's like the cart or the horse. Did the depression cause the sleep disorder, or did the sleep disorder cause the depression? And there's a relationship of sympathetic nervous system and those cholinergic neurotransmitters. So thinking about factors that can affect sleep quality and quantity, patient's age, their lifestyle, their sleep environment, their medication use, amount. So for ages, the amount and patterns of sleep are going to differ at each major stage of the life cycle. REM and non-REM sleep periods will decrease with age. So newborns, on average, are going to sleep about 17 to 18 hours a day. They're kind of like little ferrets. Newborns sleep the most, and they actually don't have distinctive sleep stages until they're about 4 months old. So sleep is differentiated into active, quiet, indeterminate. Active sleep most resembles their REM sleep, which allows for frequent wakenings to feed, and then they have active sleep for the other periods of time. So gradually, around 4 months old, they begin to sleep more at night, and the sleep stages begin to actually start to resemble adult sleep. A 6-month-old will typically sleep about 12 hours at night and nap 1 to 2 hours each day. And sleep in children plays a very important role in growth and brain development. Toddlers sleep about 11 to 12 hours at night with a 1 to 2 hour nap after lunch. And nap requirements vary depending on the child, with some children taking naps up until, kindergarten age. By age 5, children are typically sleeping about 10 hours a night, with REM sleep accounting for about 20% of that total. Now, tweens and teens, pre-adolescents, they need 10 hours of sleep. Adolescent requirements aren't very well defined, but many teenagers don't get enough sleep because of their busy schedules, their overuse of personal electronics, the academic pressures from school, and they could have growth spurts, which require more sleep, and then they're not getting that sleep. So then you get a cranky teenager. Young adults need about 8 hours of sleep, although the requirement does vary very widely. Some young adults can get away with 6 or 7, others might need 9 or 10. Lifestyle choices make this group very vulnerable to sleep disturbances. Middle-aged adults, sleep requirements may remain unchanged from their young adult age, but typically sleep disturbances during middle age are stemming from hormonal changes, breathing related disorders, endocrine disorders. Sleep problems are common among older adults. Besides taking longer to fall asleep, they spend less time in deep sleep, so their sleep is more easily interrupted or fragmented. Early awakening is also common in older adults and can result from an earlier rise in the body temperature, and because they then have to go to the bathroom. Many older adults also have trouble falling back to sleep after they've been woken up to go to the bathroom. And we always have to talk about environment. Sleep environment affects quality of sleep. Environmental influences on sleep can be excessive noise, bright lights, sunlight, excessive activity, an uncomfortable bed, an uncomfortable room temperature. When these influences are prominent, sleep is going to be difficult even for someone who's sleepy. Removing the stimuli will produce an environment that's more conducive to sleeping. So if you are that night shift worker, if you're first, you get that job on med surg when you get out of nursing school and you're working 7P to 7A, when you go home, you need to make your room as if it was, 10 o'clock at night. You need to put dark, light filtering curtains on, make the room cooler. If you live in, like I live in Florida, so making sure that you have a lower temperature while you're trying to sleep. These are all things that can help you maintain that like circadian rhythm. Socioeconomic status related to social pressure, poor environmental conditions. People, you're supposed to, purchase a new mattress every 7 years, but they're ridiculously expensive. So sometimes, people can't afford to do things like that. At the least, if you can change out your pillows, because they do become full of dust mites and dead skin cells. So if anything, if you want to treat yourselves to a new pillow, that would be something you can look into. Travel, shift work, stress, anxiety, they're all going to greatly influence sleep. A person who travels through different time zones is going to get something we call jet lag, which is worse if you're traveling from west to east. So remember that if you are one of my California students who are coming to Tampa to do your clinicals, going west to east is going to be harder on you, because our 9 o'clock, we're ready to go to bed is, your dinner time. So it's going to be a little bit harder on you to get for them early clinicals. 20% of night shift workers experience problems with sleep due to disruption of their body's natural rhythms. Medications of any kind have a potential to alter someone's sleep patterns. Prescription drugs can cause something called somnolence, which is a fancy word for drowsiness, at inappropriate times, and some can cause insomnia. And of course, use of illicit drugs can also disturb sleep patterns. Now, alcohol being a big one. Time, duration, quality sleep influenced by age. We talked about how young infants, have more sleep requirements. Adolescents need more sleep, but don't necessarily get it. All right, learning outcome 17.2, categorizing key characteristics and manifestations of current sleep disorders. Yeah. So, insomnia, sleep disordered breathing, restless leg syndrome being the most common. 13% of Americans report poor, very poor sleep. It's actually a little higher than that, especially after COVID years. Determination of sleep disorder requires significant impairment of functioning. We got issues of safety, concentrating, cardiac symptoms. Obstructive sleep apnea has a direct correlation to cardiac symptoms. And I know you guys have heard me talk about DSM-5 a lot. DSM-5 is our manual, and sleep disorders is classified under the DSM for mental health. Parasomnias, abnormal behaviors, subjective experiences, physiological events, sleepwalking, night terrors, a nightmare disorder. You can also get substance or medication-induced sleep disorder. Steroids are common, corticosteroids use for having the medication-induced sleep disorders. People who take stimulants like Adderall, Vyvanse, methylphenidate, if they have like an afternoon booster dose at like noon, but it can keep you awake. Weight loss drugs, like phentermine, those things can also keep somebody awake. So insomnia is our most common sleep disorder in adults. Repeated difficulty with sleep initiation, duration, consolidation, sleep quality despite adequate time for sleep. It will result in some form of daytime impairment, and it's associated with very high levels of morbidity, injury, poor daytime functioning, and very poor quality of life. Insomnia is something that needs to be intervened. DSM-5 allows providers to specify etiology and duration. So episodic, less than 3 months. Persistent, 3 months or longer. Or recurrent, meaning they're having 2 or more episodes within a year. And then we can go further down in the ICD coding with being chronic, short-term, or other when there's normal criteria is not met. And those ones are usually have like the 0.9 after the sleep disorder when you're doing the ICD-10 coding. So typically an event or a stressor precipitates the acute period of poor sleep. Manifestations across the domains include fatigue, anxiety, irritability, social isolation. There can be a cognitive disconnect of the bed or the bedroom with sleep. It's not, if you've ever had insomnia, it's not fun. Circadian rhythm disorders. Common symptoms, recurrent sleep disturbances. There's a disalignment between somebody's circadian system and like their work schedule or their personal environment, which will cause excessive sleepiness and impaired function. So this person's internal sleep-wake pattern is out of sync with the demands of their work schedule, their travel schedule, their social activities. What happens is we get insomnia and daytime sleepiness. So the human body has this internal clock. It's built into us. It follows a 24-hour cycle of wakefulness and sleepiness. And the clock runs on the circadian rhythm. And it's linked to nature's cycle of light and darkness. So critical organs, heart, liver, kidneys, they have their own clocks that work in a coordinated fashion with the body's master clock that's located in the brain. So researchers know that certain cardiac events, like heart attacks and sudden cardiac death, occur more during specific times of the circadian cycle. We have things like sudden infant death syndrome that occur during certain moments within that sleep cycle. So our body's clock keeps us alert during the daytime and it makes us sleepy when the night falls. And all of our physiological functions are geared toward being active during the day and resting at night. And the desire to sleep is like a normal sleep desire should be between midnight and 6 a.m. Nonetheless, though, individual patterns of alertness will vary, explaining why some people are more alert during the day and they're called larks, whereas other people are more alert at night and we call those night owls. And then sometimes people fall somewhere in between. So we have this thing called melatonin, right? You've all heard about melatonin. People may have taken melatonin, but we make our own. So our internal clock is influenced by melatonin, and that's a hormone that causes sleepiness. Like your body actually produces melatonin. It's secreted by this little thing called the pineal gland, which is located on the roof of the brain's third ventricle, if you remember back to your anatomy and physiology classes. So that's influenced by light. The pineal gland will slow melatonin production during daylight hours to promote alertness, and it will increase production when darkness falls so that you become sleepy. So with age, the body starts to produce less melatonin. So not surprisingly, elderly people suffer from more sleep disorders. There's some pharmacological therapies to try to increase the level of melatonin or enhance its effectiveness to try and readjust our internal clocks. Now, circadian refers to that biological rhythm of 24 hours. Circadian comes from, a Latin term of circa, which means, going around, and diem meaning day. The circadian rhythm functions as the body's internal clock, regulating that 24-hour sleep-wake cycle and regulating body temperature, hormone secretion, and your heart rate. So your body's internal clock can reset itself to help a person adjust to disturbances such as seasonal changes, like when we have our uh, daylight savings, time starting or ending, unless you live in Arizona because they don't believe in it. So we have, or like the start of a new work week. If you tend to go out Friday and Saturday night, your body can reset itself, for you to be able to go back to work on Monday. So it can't always overcome long-lasting disruptions, though. So jet lag, going across these time zones, doing shift work. So if you work, 7 to 3 this week, and then you're working 3 to 11 this week, and you're working 7 p to 7 a the next week, that can throw these circadian rhythm disorders, crazy. So shift work disorder is a huge thing. We can get disruption of circadian rhythms causing poor judgment and decision making, and it can cause a lot of GI disorders. And there's different types of circadian rhythm sleep wake disorders as well. We have a delayed sleep wake phase disorder where the patient sleeps according to a delayed clock time, which could be because of social, economic, or family demands. And typically, individuals have trouble falling asleep until the early hours of the morning, and they end up sleeping through much of the day. This disorder can begin in childhood and is very common among adolescents. And that's where people will get the term, like, start getting coined, like that they're a night owl. And I think I fall into that, where my brain's most active period, like I feel the best, is if I stay up and do my work until like 2 a.m. and then go to bed and don't get up till about 10 a.m. If I have to get up early to do something at like 7 o'clock in the morning, my brain is not a happy camper, because my own natural circadian rhythm and hormone production has my brain most active between 11 a.m. and midnight. So circadian rhythm disorders can result from intrinsic or extrinsic factors. Intrinsic factors are um, things that can deviate from societal norms. Extrinsic factors occur when when your circadian rhythm is in sync with light and dark cycles. But lifestyle factors like jet lag or shift work is where it's going to impact that sleep. Yes, nurse. So right here, that last one, nurses are prime candidates for circadian rhythm disorders because we work hours that don't coincide to when our brain is the most active. So this OSA and CSA, these are important because these will go not just for mental health. I mean, we talk about them in the psychiatric class, but this is huge in your primary care and in your just your regular med surg acute care. So many patients with obstructive sleep apnea are overweight and they have short, thick necks or they have fat infiltration around the pharynx, which will increase the risk of an airway blockage. Some people have unusually large soft palates or have like large tonsils or a large tongue, and that can cause obstructive sleep apnea. In people who aren't overweight, OSA typically results from a small upper airway or an oval-shaped airway or a very long upper airway. And other structural causes of OSA could be malformations of the oropharynx or their jaw, or they have tumors or growths that narrow the airway. And among elderly adults, it's mainly from loss of muscle tone that will contribute to the condition. People with rotating work schedules are at the highest risk of having OSA. The use of alcohol or sedatives can increase the frequency and the length of these apneic episodes. So, signs and symptoms. Patients with OSA are going to report chronic daytime sleepiness. They are going to report snoring, which may be pronounced enough to disturb the sleep of other household members. So, in fact, the patient may not even be aware of the heavy snoring and nocturnal arousals. So, we need to ask the family members, does your husband or your wife snore? Other symptoms in someone with OSA is they awake in the morning and they feel like they didn't sleep. They have frequent headaches. They have a general feeling of tiredness and fatigue. They need daytime naps. And then they take the daytime nap and it didn't restore any energy. They're irritable. They have difficulty paying attention. They have learning or memory problems. They have depression. They get excessive urination at night. They get impotence. They can have heartburn or acid indigestion, which is suggestive of esophageal reflux. Repetitive cycles of snoring, airway collapse, and arousal can lead to an increased risk of diabetes, of cardiovascular problems, hypertension, arrhythmia, myocardial infarctions. You can even have a stroke because of this. So some high-risk patients, sleep apnea may lead to sudden death from respiratory arrest while the person is sleeping. Frequent awakenings leave the patient sleepy during the day, causing irritability, causing mental health disorders, causing anxiety, causing depression. The patient may experience morning headaches, impaired mental functioning, and a reduced sex drive. People with severe untreated sleep apnea have a 2 to 3 times higher risk of being in a motor vehicle accident. So sleep apnea is very common. It affects about 22% of men and about 17% of women. And then treatments for OSA include lifestyle changes, CPAP therapy, dental devices that could modify the tongue or the jaw position. And then we have our polysomnography. It's a sleep study, fancy word for sleep study. So nursing interventions. Remember that the patient is likely to be tired and irritable. So I want you guys to be helpful and supportive. Nobody really gets restful sleep in the hospital, even if they are a good sleeper. If the patient reports associated symptoms like esophageal reflux or nocturia, Impotence, we need to refer them for appropriate treatment. We need to assist the patient in a weight loss program, if weight is an issue causing the OSA. You need to advise a patient to stop smoking because smoking is tied to OSA. Encourage our patients to avoid alcohol use and illicit drug use. And we need to help family members deal with issues related to the patient's, snoring or gasping or whatever else is going on that's keeping everybody in the house from getting a good sleep. And so this sleep study is an overnight test that's performed. We used to do them in special laboratories or sleep centers, but now the technology has gotten so good that we can actually have people do sleep studies in their house, in their own bed, in their own environment. Brainwave activity is recorded by an EEG. The EEG reveals the stage of sleep that the person is in at any given time. It records eye movements to see if the patient's experiencing the REM sleep. We look at muscle movements. They can put EMGs. If you do the one that's like in the hospital, they do EMGs. And that does a recording, which helps us document wakeful periods, arousal, or any spastic movements. We look at respiratory effort, chest abdominal excursion during breathing. They put Velcro bands around the patient's chest and their abdomen, and that's connected to a little transducer. And the force of the chest and abdominal expansion on the bands will give us an idea of how much they're struggling to breathe. Always looking at oxygen saturation while they're sleeping, having a pulse ox on the finger or the earlobe. We could do continuous EKG monitoring and to see if low oxygen saturation can occur during like an apneic episode and whether or not there's any kind of arrhythmia going on during that apneic episode. Airflow, they put the little airflow thing on the septum of the, in the nose, and it records the amount of air that moves in and out of the airways. So then we can find if someone's hypoapneic or apneic. And we gotta look at the blood pressure to detect dangerous blood pressure elevations, which can be caused by apneic episodes. All right. So we got lots of stuff going on with sleep. Collapse of the posterior pharynx during sleep, congenital structures, poor muscle tone. That's more in your elderly patients. People could have small pharyngeal openings. Anatomically crowded airway from fatty deposits, most likely because of obesity. Treatment includes CPAP or surgery. Multifactorial development of OSA. Risk factors: obesity, male gender, snoring, witnessed apnea from family members, genetic disorders, and good old menopause. Risk factors for developing the central is medical conditions that affect cardiac and respiratory systems, different medications, and people older than 65. Good old restless leg syndrome. And where are my notes on? That's my narcolepsy notes. So restless legs is a neurological disorder. You get these unpleasant sensations in your legs. It can be like almost like maybe like bugs crawling under the skin. So it gives you this desire to have to like move your legs and arms. And it usually increases as the day goes on. And there's periodic limb movements, which is a separate disorder from RLS. We get fragmented sleep, inability to, I think that was a typo there. And then we get disruption of the partner's sleep. All right, so here's different sleep-wake disorders and how it affects the different domains. So insomnia, we have manifestations by biological, psychological, social, cultural, and spiritual. So in insomnia, you're looking at decreased immune function. We have fatigue, Depression, anxiety, irritability, decreased cognitive performance, social isolation, disinterested in attending activities, breathing related disorders, hypertension, cardiac disease with left ventricular dysfunction. Remember that left ventricle is your powerhouse, right? Or the left side there. So altered glucose metabolism, it can cause pedal edema, and it can be caused by obesity. Anxiety, depression, impaired cognitive function. Now you guys can read the chart. It's all of these are in your book, and they're in your PowerPoints. To talk about narcolepsy, I know you see it sometimes, in the movies, and the person's, just talking and then like falls down and is snoring. It's not quite as dramatic as that, but narcolepsy is characterized by sudden, uncontrollable attacks of deep sleep lasting 20 minutes. These sleep attacks come on without any warning, and they can be accompanied by paralysis and hallucinations. And although the brief sleep is refreshing for the person, the urge to sleep will return. So sleep paralysis and hallucinations, they typically occur during sleep onset or during that transition from sleep to wakefulness. And they're usually visual hallucinations, but they're very intense images. And they commonly involve whatever's in the immediate environment. And some patients with narcolepsy experience attacks of what's called cataplexy, which is a sudden loss of muscle tone and strength. Their head could drop, their jaw could slack. It's commonly triggered by intense positive emotions. For example, like your knees will buckle after a patient like laughs or gets angry or feels super surprised. And cataplexy typically lasts just a few seconds, and the patient remains alert during the episode. However, in severe cases, the patient could fall down, become completely paralyzed, and it can last, up to like 2 minutes. So complications. Narcoleptic sleep attacks occur any time of the day. All too often, they occur during activities that call for the person's undivided attention, like driving a car or being at work. Narcolepsy can be disabling. It can impair your work performance. It can become very disrupting for your leisure activities, for your interpersonal relationships. Coworkers could perceive you as lazy. An employer might suspect that you are taking illicit drugs. And in children, narcolepsy impairs school performance and social relationships. I can invite ridicule from your peers, and teenagers with the disorder are at a very high increased risk of having automobile accidents. So diagnosis is a history of excessive daytime sleepiness, uncontrollable sleep, observed cataplexy, strongly suggests that this person has narcolepsy. There's other possible causes for daytime sleepiness, like heart disease and brain tumors, anemia, and depression. So they usually do an overnight sleep study. And the time required to fall asleep is, they do an average. So in narcolepsy, sleep latency is it's like less than 8 minutes. So the diagnosis is confirmed by using the criteria that's in that DSM-5. And our main treatment right now is modafinil, which is a CNS stimulant. So that promotes wakefulness and alertness. So a name brand is called Provigil, and it's used to, it's pretty safe and generally well tolerated, and it's less likely to cause issues than like traditional stimulants, like amphetamines or methylphenidate. So it's less likely to cause the jitteriness, anxiety, excessive motor activity, or like a rebound effect. So it's a pretty, decent drug. And of course, with any drug, you always have to do your nursing education. So 17.3, categorize key characteristics and manifestations and disorders of wakefulness. So disorders of wakefulness. Most common sign is excessive daytime sleepiness in the absence of a sleep disorder. Can result in life-threatening motor vehicle and work-related accidents, and it can affect patient and community safety. So this was the narcolepsy that we just talked about. 10% of those with narcolepsy experience the cataplexy. Diagnosis is made through that in-house sleep study. Comorbid with anxiety, eating disorders, depression, and psychotic symptoms. And the treatment is mainly pharmacological. With most of the time, they're using traditional stimulants. We have hypersomnolence disorder, so excessive daytime sleepiness despite a main sleep period of at least 7 hours. So the person went to bed, they slept well, but they get up in the morning and they felt like they haven't slept. So it's a patient can exhibit very automatic behaviors. They may have trouble meeting work and family obligations. Driving can become hard. The diagnosis of hypersomnolence disorder is reserved for patients who have no other direct cause of daytime sleepiness, such as obstructive sleep apnea or narcolepsy. The primary symptom associated with hypersomnolence disorder is feeling tired to the point where the feeling interferes with the activities of daily living. So patients may report extended sleep periods at night, the desire to nap frequently during the day, and in some cases, behavior upon awakening can resemble the person actually looking like they're a little bit drunk. They can have a manifestation of confusion, disorientation, or motor function, or very slowness on awakening. So even after like 12 hours of sleep, a patient with hypersomnia will still feel drowsy. So evaluate different pharmacological and non-pharmacological therapies used in the treatment of individuals experiencing a sleep-wake disorder. Interprofessional care treatments vary according to the disorder and usually involve more than one type of therapy. We need to elicit from the patient which symptoms, impairments, and functionings are the most troublesome for them, and talk about the patient's sleep partner and know how their sleep is going. And we got our sleep study, psychopharmacological over-the-counter meds, diphenhydramine. We try not to use that anymore. That's Benadryl. That's not a drug that needs to be used on a long-term basis. We're actually finding out that it's causing a lot more long-term implications than was previously thought. And that's pretty much any of these like Tylenol PMs that everybody's been, taking. You're pretty much overdosing yourself on a drug that's going to eventually cause liver damage. So addressing why you're not sleeping is more important than taking these meds on a long-term basis. And alcohol should always be avoided because it is not it is a CNS depressant, but it's not one that's going to put you into restful sleep. Benzodiazepines and other CNS depressants reduced time taken to get to sleep may decrease the frequency of night and early morning awakenings. These are some of your Z drugs are used in this CNS world here and your benzos. We have non-barbiturate hypnotics. We use caution in those if a person has depression or alcohol use. We cannot use any of these in pregnancy. And for Zolpium or Ambien, we try to use a very low dose in our elderly population. Alcohol use and psychological stress can lead to a lot of this hypersomnolence on a temporary basis. Viral infections like HIV, pneumonia, mononucleosis, Guillain-Barré, they can also all lead to hypersomnolence. Even after the infectious process resolves, patients continue to need significantly more sleep and still feel tired when they wake up, especially that mono. That has been known to lead to something like, chronic fatigue syndrome. And there's usually some kind of co-diagnosis with Epstein-Barr syndrome, and that hangs out in your body for a long time and it can reawaken, causing chronic fatigue. Over-the-counter and complementary therapies should always be accompanied by an appropriate assessment and the diagnosis of what the sleep disorder is. Diphenhydramine should not be used anymore. Antihistamines result in the impairment of your ability to drive. This can last up to 18 hours because it is anticholinergic. It dries everything out. Over-the-counter sleep aids are not recommended, especially if you have sleep apnea. Valerian root and over-the-counter melatonin can be helpful, but it is for short-term use. If you have a need to take these medications every single day, we need to address the root cause of why you are not able to sleep. We have cognitive behavioral therapy. CBT can be used for a lot of different things. It can also be used for insomnia because we want to address the negative sleep behaviors, possible beliefs surrounding your sleep issues or your cognition. And it may be necessary if sleep disturbance continues after the comorbid sleep disorder is actually treated. If we fix the issue that's going on, but you're still having negative sleep behaviors, it could be psychological, and that's where the CBT is going to come into play. Plan evidence-based care for patients with this disorder. So remember our nursing process: assessment, diagnosis, planning, implementation, and evaluation, ADPI. So many patients reporting sleeping difficulty may not experience an actual disorder, so we need a thorough assessment. Was it that they were up all night cramming for a test? So sleepiness can be caused by numerous precipitating factors, medications, side effects, a neurological injury if they had a motor vehicle accident. So we do our full assessment. We're using the algorithm. We're screening patients for that OSA, screening them for narcolepsy. We're doing that sleepiness scale. Do you have difficulty falling or staying asleep? Have you been told that you hold your breath? Do you snore? Do you stop breathing while you're sleeping? Do you feel sleepy during the day? Does work or other activities prevent you from getting 7 hours of sleep during the night? And there's your different algorithms for assessing. So, how they answer it, you kind of just follow that little algorithm down. Alcohol, caffeine, and anxiety are huge culprits in persistent insomnia. A patient with insomnia can have difficulty falling asleep, staying asleep. They wake up too early. They can't go back to bed. They get non-restorative sleep. They get a haggard appearance, irritable, short attention span, poor concentration, excessive anxiety over their health, interpersonal, social, occupational problems stemming from the anxiety over not being able to sleep. We need to make sure they're not having an inappropriate use of sedatives, alcohol, or caffeine. Diagnosis and planning. Determine the appropriate nursing diagnosis related to the sleep disturbance or inability to sleep. If you do not know nursing diagnosis or you have not looked at NANDA, I highly suggest you either get a NANDA nursing diagnosis textbook or go on to Google and see which resources you can find, because nursing care plans are going to be something you are going to see every single day when you are working out in the hospital. You might not do them so much if you're working in an office space, but even if you're in the nursing home, they're doing care plans and you need to know how to do them. And plan of care should always include an appropriate sleep hygiene. We turn off your electronics. Don't lay in bed and read. Don't lay in bed and watch TV. Don't lay in bed and eat. Determine most distressing symptoms for the patient or the partner. We want to involve all the domains: biological, psychological, sociological, cultural, spiritual, and that includes CPAP and sexuality. It is not very sexy to look over at your partner with this big mask on their face. They have gotten a lot better with CPAP and BiPAP, that they are a lot more discreet now, but you can see how it could affect somebody's self-esteem. So revising our care plan during recovery and rehab, we always want to revise. We set goals. We need to evaluate those goals. You guys are doing this in your concept maps every week. You are giving me measurable outcomes. Patient will exhibit, patient will sleep, 7 hours uninterrupted. I set a goal like for 3 days in a row, or patient will, you know, return demonstrate, proper sleep hygiene. You have to make sure every goal is measurable. Patient will apply CPAP, every single night, by discharge, or like, will express that the desire to, wear their CPAP, by discharge. And then we're going to reinforce what the negative health effects are going to be if we do not treat. We have implementation. So individualized interventions may include education on their medication, on what normal sleep requirements are, consequences of insufficient sleep, how to assess appropriate referrals and or how to access appropriate referrals and treatment, and our sleep hygiene, relaxation techniques, because patients with insomnia have high levels of cognitive arousal. Relaxation-based interventions can provide a lot of relief. So techniques that help them deactivate that arousal system, like progressive muscle relaxation, abdominal and deep breathing, biofeedback, bioimagery, these things can all be implemented to help these patients. Sleep hygiene is very, very important. Insomnia responds very well to lifestyle changes, and that's part of that sleep hygiene. So, going to bed the same time every night, optimizing your sleep conditions, avoiding naps during the day. Sometimes people they'll take a nap and and it will not be 20 minutes like we recommend. They'll take like a 3 hour nap, and then come bedtime, now they got a second wind and they can't go to sleep. We have to do behavioral interventions. We have to aim to change maladaptive sleep habits. We need to reduce that autonomic arousal. We need to fix altered dysfunctional beliefs and attitudes. And there's a wide range of behavioral techniques that can be used for insomnia. Stimulus control is a behavioral intervention. It connects behavior associated with sleep to the patient's actual sleep behavior. So, with, like, for example, behavioral interventions, patients are instructed to go to bed only when sleepy and make the behavioral choice to get out of bed when they realize that sleep is not naturally occurring after a brief period of time. Stimulus control is based on the theory that insomnia represents a learned response to bedtime and bedroom cues. So you have to give instruction. So you're going to use your bed for patients who have this kind of insomnia. You are going to use your bed only for sleeping, or, sexual functions, but mainly for sleeping. And if you can't fall asleep or you can't stay asleep, then you need to get out of bed and go to another room and return to your bed when you feel sleepy. Awaken and get out of your bed every time in the morning, regardless of how much sleep you got. Get in the habit of getting up and trying to avoid those naps. Sleep diaries are very, very important. So implementation, primary, secondary, tertiary, you're always going to hear these words over and over again. Primary prevention, we're trying to actually prevent it from before it happens rather than fixing it after it happens. So primary is lifestyle modifications, managing those medical issues. Secondary, we already know you got it. We're doing the detection, we're doing the treatment, we're trying to prevent complications. Tertiary, it's already happened. Things have went wrong now. So now we need rehab. We want to promote strategies for treatment adherence. Patient education, normal sleep, stimulus, sleep hygiene, medications, all the things that we just, talked about. Sleep promoting measures, using the bed only for sleep or sex, not for reading, not for watching television, not for working, which is I'm doing actually right now, recording this Zoom lecture, is laying in my bed. We want to establish a regular bedtime and a regular time for getting up in the morning. We're going to stick to these times, even if we're on vacation or even if it's the weekend. We want to exercise in the evening because energy levels bottom out a few hours after exercise, which will promote sleep. So during the 30 minutes before bedtime, you need to do something quiet or relaxing. We need to keep the bedroom quiet and dark and cool and well ventilated. We need to eat dinner like 4 to 5 hours before bedtime. We need to spend at least 30 minutes in the sun every day, because that is going to help with that melatonin production. So, what not to do? We don't want, we're not going to use our bedroom for work, reading, watching TV. We're going to avoid large meals before bedtime. We're not going to look at the clock. We're not going to obsess over the time. We're not going to look at our watch and go, if I fall asleep right now, I'll get 4 hours of sleep. If I fall asleep right now, I'll get 3.5 hours of sleep. Don't look at any of that. Don't smoke before bed because nicotine can cause sleep loss. You shouldn't smoke at all, but definitely don't smoke before bed. Um, Try not to toss and turn in bed. If you're getting anxious or your body's not settling down, get up and go take a walk. Don't go watch TV out in the living room though, because that's going to emit too much light and it's going to mess up that melatonin. So you have your sleep hygiene guidelines. These are also in your book. It gives you the guideline, it gives you the rationale. Cut down on all your caffeine products. They cause difficulty falling asleep. Put the clock under the bed and turn it off so you can't see it. Avoiding the naps, using the bedroom for sleeping and intimate activity only. Implementation, interventions to promote sleep in the hospital setting. It's very hard to get rest in a sleep environment, especially when you have people coming in and taking your vital signs every 2 to 4 hours. So encourage quiet sleep, environment free of staff, chatter. If you were at the nurse's station, if you're doing your charting outside the room and you and your coworker are having a conversation about what you want to buy from J.C. Penney's and your patient is in the room, they can hear you. So take your conversations someplace else. Be very cognizant of how loud you are being at the nurse's station. We're going to do evaluation. Remember at ADPI, we always got to evaluate, assess for adherence, make sure that they have knowledge that they're following their recommended treatment. Sleep disorders are treatable. There's several options for treatment. So we play a very key role in recognizing, initiating referrals, and educating our patients. All right, and then there's an appendix that's in there. So basically, that is your chapter 17. If you guys want to do any like NCLEX style questions, we can always do them this semester. Otherwise, do your reading, do your concept maps, and make sure that you take your quizzes before Sunday evening at midnight.